Hi guys, I am Dr. Baran Erdik. I am the compliance and regulatory consultant for CCM Health, and today we'll be talking about a patient-centered medical home. Basically, we'll be talking about what it is, how we got here, is there any evidence for it, and how do we get reimbursed, and why should we get reimbursed, right? That's always a major question. So if we look at the objective, we need to first understand the landscape, and that goes with looking at macro and myths. After that, we need to define what PCMH is, if there's any evidence behind it, what the basics of it is, and what the costs of it is. So let's start with the patient, right? So let's say a 59-year-old comes into your office, she wants to lose weight. Been following the pandemic diligently and then lost family members. They were obese. She's worried about diabetes. She's worried about COVID. She's worried about dying in an ICU. I mean, she does everything wrong though. She drinks a lot of sweet tea. She loves McDonald's, and she also smokes, and she's a social drinker. So, I mean, we build this, right? We see her, we spend 10 minutes, we spend 10 minutes charting. What do we owe her ultimately though? Just a 15-minute visit, that's it? Is that all that's owed to her by her medical provider? I mean, what are we gonna do? Maybe give her some metformin, lecture her on lifestyle changes as if she probably doesn't already know. Like maybe even semaglutide, if she's lucky to have insurance that'll cover it for her obesity. What's gonna happen to her though? What do you expect in 5 years, 10 years? Is she gonna get better? Is she gonna be hospitalized? Is she gonna have sequelae of her disease? She gonna die from COVID. So what do we do? What do we need to do? So that's where PCMH comes in. So for us to understand how this is all tied together, we need to first understand MACRA. So MACRA is the Medicare Access and Cheap Reauthorization Act of 2015. So basically, it replaced the formula, the sustainable growth formula that you all may remember for how Medicare reimbursement was determined. So ultimately, it provided new approaches to Medicare reimbursement, making value and quality keys. So before, when this first started happening in middle 1900s, right, it was just fee for service. You saw a patient, you billed, you got paid. You did a surgery, you billed, you got paid. So now we are moving away from it. We are moving to more of a value and quality based approach. So you need to show that what you're doing is actually high quality and creates further value downstream. So that brings us to the two separate pathways that this MACRA Act created. So these are the payment pathways. We have the merit-based incentive payment system, the MIPS, and then we have the advanced alternative payment models, advanced APMs. So PCMH is an advanced APM. First, why? Why was this even needed? Well, ultimately, if you look at the healthcare costs, it's been unsustainable. I mean, it's just been to the moon, right? It's just been going up and up and up with no end in sight. So basically, the Congress is trying to reel this in. If they can even a little bit, I'm sure that'll be helpful. Some critics that'll say about the US as the best healthcare system, we gotta pay for it. Well, not necessarily, right? So you spend the most per capita, you don't even get the life expectancy. And bear in mind, this is a couple years old data with COVID and everything. This has been gone down even further. Same thing, if you look at the change from 1990 to 2015, you're not really changing that much. You're going in the negative direction to an extent, and then not as good. So like even from just a mortality from an ischemic heart disease perspective, you're just middle of the pack, right? So you're not really good. So ultimately, US is paying the most, not getting the most. What are we going to do about it? So that brings us to an extent somewhat to PCMH. So critics of it will say that it is socialized medicine. It'll kill patient access because ultimately people can come in. when they want to come. So all in all, as I said, US pays the most but doesn't get the most. So PCMH was sort of idealized with that in mind. So it's actually an old concept. It's nothing that new. It was introduced and defined in 1967 by the American Academy of Pediatrics because they figured they would need a central location for archiving medical records for children with special needs. Ultimately, it was expanded to include accessible, continuous, comprehensive, family-centered, coordinated, compassionate, and culturally sensitive care in 2002. And in 2007, American Academy of Family Physicians, College of Physicians, and all the other bodies created joint principles. And finally, in 2008, the National Committee on Quality Assurance, so NCQA, finally created criteria. Again, though, what is it? So to understand, we need to start with some definitions. So these are going to be a couple long slides, but they're just definitions. So the NCQA definition is that the PCMH is a model for care provided by physician practices aimed at strengthening the physician-patient relationship, replacing episodic care-based illness, patient complaints, coordinated care, and a long-term healing relationship. So TLDR, basically, we do not treat the disease, we treat the patient. There's also a CDC definition, which is going to be, again, similar. So medical home is a model or philosophy that is comprehensive, team-based, coordinated, accessible, focused on quality and safety, yada, yada. So if you see, almost every definition has these buzzwords repeating that are at the core of a PCMH: patient-centered, comprehensive, team-based, coordinated, accessible, quality, safety. So basically, it is everything that an ideal healthcare system needs. So patient-centered means you're supporting families in their decisions and care plans. Accessible is that care is delivered with short waiting times, there's good access and extended in-person hours. Committed quality and safety shows that you're using health IT, decision support, other tools as needed. Coordinated is that it's organized, right? You don't just tell patient to go somewhere, you actually have them organize it. And comprehensive is whole person care based. So basically, patient-centered supports the families and helps them become fully informed partners. You don't just tell the patient to go take their metformin. You explain to them. You make them understand why they should take that metformin, how it'll benefit them, and what it does. And this is important at a practice, community, and policy level, because from a practice level, you may try to do it, but from a policy level, if the insurers are willing to pay you only for 5 minutes of your time, after a while, it's not going to be feasible. Same thing goes with community. If the community is more in tune with reading up on the medical news on Facebook or whatever it's called these days, Meta, so they may not be as in tune to your explanation. How do we do this? I mean, it all boils down to relationship, right? So we need to have people trust in us, in the care, in the system, as well as we need to provide compassionate and culturally right care. What will this get us? Patients are going to be less likely to doctor shop, and they're more likely to trust the judgment of physicians and then continue treatment. It is just sometimes mind-baffling that people just turn to the internet or the Facebook or whatever instead of a physician judgment. But if they have an issue with the judicial system, they do not turn to the internet for guidance from a lawyer. So there's some trust issues ongoing here. So we said it needs to be comprehensive, meaning the doctor is the captain of the ship. That's where the care or the box stops. So they are responsible for the patient's whole health, both physical and mental. And that doesn't mean that they just treat the acute episodes, right? They need to include prevention, wellness, chronic care. So you do not treat the patients. You do not treat the disease, you treat the patients. So another thing PCPs can possibly do as a PCMH is relocate or co-locate with OB-GYNs or pets or pediatrics or whatever they need to. It needs to be coordinated. Why? Well, because it needs to be organized, right? So we don't want the patient having 5 MRIs because they lost the report, or we don't want to have the patients have to go to 2 cardiologists because there was no referral report, or they didn't know what happened during their visit. So basically, these need to be documented and communicated. So if a referral is a reported visit, if there's no report, that's not a referral. So patients also should and be enabled to connect without limits through the EHR. So they should be partners in their own care. And ultimately, this will lead us to order less duplicate tests, and there will be better follow-up. We said it needs to be accessible. I mean, most people work 9 to 5 office hours, right? It's not easy, especially in the US healthcare, for them to take time off to go to the doctor, especially during the middle of the day. US doesn't even have paid leave. So even if they're especially sick, they may not have any leave. So with all those things in mind, a lot of people overuse the ER. That adds to both the cost and the complexities of the system. So we need to provide under a PCMH umbrella consumer-friendly services, enable us to have shorter wait times, extended hours, like maybe we're going to stay open till late, but we're going to start late. And 7/24, 24/7 electronic and telephone access. So the patient can get sort of an answer before going to the ER, because usually they do that when it's their only choice, as their studies have shown. So if like we can maybe see a patient first thing in the morning at 7 a.m., we may avert that ER visit. Same thing can work with telemedicine. If they're so sick, they can't really get out of the house, or with the advent of the SARS-CoV-2 virus and the COVID-19 pandemic, they do not want to infect other people, we can just see them over the computer. So ultimately, we'll get less ER visits, better care, better management, and less doctor shopping. And I can hear some of you all thinking, I mean, you're saying all of this, but yeah, is it really worthwhile? Yes, there's evidence for all of this, and I have compiled a huge list of evidence that I'll share with you towards the further down the line, towards the end of the presentation. And finally, commitment to quality and safety. So this demonstrates quality improvements through health IT and similar tools to make sure that the families and patients are making informed decisions. How are we doing this? EHR, clinical decision support, medication management, evidence-based medicine. So basically, if we give the best care possible, I mean, it's going to be prevention and better outcomes and savings. So this is not 1950 anymore, right? We are not doing paternalistic medicine because that's the way we learned it in medical school. Times are changing, evidence is changing, and we need to keep up with it. So, I mean, from a PCMH perspective, ultimately, we're trying to change treating the disease to treating the patient. Goes against a lot of things we've done in medical school, but ultimately, that's the way forward. That's the path forward. Your fragmented care becomes collaborative. So like, oh, the patient sees Dr. Angel in cardiology. 2 days later, they see Dr. Haku in orthopedics. 5 days later, they see Dr. Hooker in endocrinology. So like all of this is fragmented, right? So basically it's becoming collaborative. So everyone's like writing to each other. They are ensuring there's good follow-up. Specialty driven becomes primary care based. So the primary care is the captain of the ship. They are letting the specialties know what to do. So imagine you're a captain on the Star Trek, right? So, oh, you may have the weapons department, that's specialty. You may have the engine department, that's specialty. So you need a captain, and that captain is the primary care. Ultimately, the isolated patient records become integrated, and then fee-for-service will, in the future, become shared risk reward. So there is a push towards more per member per fee or capitation style payments, meaning you get a set fee no matter what happens. And then it's up to you if those patients don't need healthcare much, you reap the profits. If they do, you don't reap the profits. So ultimately, this is what I'm trying to say. Currently, a patient is moving from PCP, insurance company specialist, medical assistant, another specialist, another pharmacist. It's just really fragmentalized. So ultimately, we need to all bring this together to a single person or single office, I guess, that can and that should and that will handle all of this. So it is evidence-backed. There's moderately strong evidence that it has a positive impact on patient experience and moderate positive effect on preventive care, as well as staff experience. So it's not just good for patients, it's also good for the staff. So if we were to look at some of the evidence that's out there, I mean, patient experience, there's good evidence and it's direct. Staff experience, meaning you're showing lower staff turnaround and happier staff. And then if you look at maybe clinical outcomes, somewhat insufficient, but from a hospital admission perspective, they're sufficient. And then you'll be able to download these slides. So I'm not going to spend 2 hours just going over every piece of evidence that I found that's out there, but you are more than welcome to look at what tickles your fancy. So from an economic perspective, there is a lot of evidence out there that shows that this is really worth your while as well. Ultimately, different studies have found different changes, but like one study shows about $400, the other study shows about $100, but there's almost all of them find the difference, right? So that's important to know. Like, so it shows savings, so it's worthwhile. Some of these are going to be old because this PCMH has been here for a while, and some of them are reported by different companies, insurance companies that is, so they may have different cutoffs or they may have different payment schedules or fees that may have been affecting this, so they're not necessarily peer reviewed, but again, they'll show savings. So for example, the Oregon Coordinated Care Organization shows almost 20% reduction in ER visit spending, or Vermont Blueprint for Health shows lower spending if you're in a per member per year spending show, or if you look at Care First PCBS, 267 million avoided costs in 2 years. That's almost 130 million savings just per one relatively big insurance company per year. So, I mean, the savings are ginormous just from a US healthcare perspective. Again, outcomes show fewer ED hospital visits. For example, if you look at Aetna, there's 35% fewer hospital admissions in 1 year. Or if you look at Rhode Island Chronic Care Sustainability Initiative, there's multi-payer, but still 11.6 fewer ambulatory sensitive ED visits, fewer inpatient hospitalizations. So helps us save those precious ER rooms in the times of the pandemic, and then helps us save money while doing it. Improved access directly also leads to lower ER visits and increased primary care visits. So different parts of this PCMH come together to work as one. And then improved health. Yes, it does improve health. Anthem Blue Cross, ACOs. So there was an increase in meeting quality measures, the diabetes LDL measures back in 2014. Some of that has changed, but still 3.8% in cholesterol management for heart disease patients, or improved blood pressure control from 67% to 79%. And then this is not Berlin, Germany, this is Berlin, Pennsylvania. How about clinician satisfaction? So yeah, patients will be obviously satisfied, but how about clinicians? Lower staff burnout. That's one key important thing that keeps popping up in this evidence, is that staff turnaround and staff burnout is low. and as well as the satisfaction rating among members is high. This is also increased preventive services, so meaning people are being screened better, so we are preventing a lot of chronic diseases and cancers. What I looked and I would have loved to see was any sort of PCMH types of vaccinations, especially COVID, but there don't seem to be any data as of now. Still early, so hopefully in a year or two we'll start getting more evidence for PCMH in the times of COVID. So, and then increased preventive services, if we look at, for example, even tobacco cessation, right? So it's improved from 36% to 86%. So only almost 1 in 3 people were getting advice from their physicians or whomever they were seeing in the office that they should stop smoking. Now it is almost all of them. How about a behavioral health perspective? Yeah, from a behavioral health perspective, you have lower ED use, you have lower hospitalization, you have lower turnaround. I did find a couple studies that were actually also looking at mandatory psychiatric holds, but there don't seem to be, because at the end of the day, if they show up at the ER, even if they just need a refill, they need to be discharged, they are typically immediately put on a psychiatric hold, at least in my neck of the woods. So there wasn't that much change on that. Oral health. Again, PCMH is supposed to take care of the patient wholly, right? So that covers oral health as well. So there were, again, if you provided dental cleanings, that turned out to benefit other things. I mean, granted, correlation never proves causation, but if they're correlated, there seems to be some sort of, be it casual or causal or whatever sort relationship there. Is there anything else I can say? I mean, not really. The data is the evidence, right? There's so much of it. Mortality, step experience. So you name it, the data is there. Okay, let's pause here for a second. And then if you want, you can move the evidence to after I talk about accreditation. It's up to you, because at the beginning we talked about the like what we were gonna do, the agenda, right? And then the agenda was we were gonna talk about the evidence after, but it's up to you, it doesn't matter.
I don't know. We are following the order you provided us, so.
No, I know. I'm just giving you options. If we need to change it, we can ask what's his name, Stan too.
Sure. Okay.
Okay. So, continuing on, what about other evidence, right? So we talked about evidence over evidence over evidence. So ultimately, PCMH has 7 key components, and there's variability to approach. No one will tell you how to best approach something. You have to meet the criteria yourself. So basically, from a financial model and implementation perspective, fee for service per member per month, stipends, MIPS, MACRA, every one of these are described in the evidence. From an implementation perspective, audit and feedback seem to be the most common strategies. And then if you have learning collaboratives and collaborative planning, they have high staff experience and retention, meaning staff have to play an important role in PCMH. You can't just bring it on as a top-down initiative and expect everyone to be on board. You have to educate them, you have to meet with them, you have to enable them to be active partners in what is a huge endeavor that is PCMH. So what about PCMH accreditation? Currently, there's 4 accrediting bodies. You have the NCQA, you have the URAC, the Utilization Review Accreditation Commission. You have the AAAHC, and then you have the JCO. So JCO and AAAHC do not publicly provide their program elements. URAC and the NCQA do, and they're about the same. So I would expect the JCO and then the AAAHC to be similar as well. For the purpose of this webinar, we'll be focusing on the NCQA because that's the most ubiquitous. So basically, you need to be providing a patient-centered access, team-based care, population health management, care management and support, care coordination and care transitions, performance measurement, and quality improvement. So there's 6 must-pass standards with 27 total elements and 149 factors. So you are required to have written processes and procedures and standards, and you need to monitor these for compliance. There's 3 levels of MCQA. Start at level 1, but it's just going out because level 1 didn't necessarily require EHR. I mean, it's what, 2021 now? Yes, you're going to require an EHR. So everything's going to be level 2 or not 3. So for level 1, you do not require EHR. You do not require registry and tracking. Emphasis on providing better care to access, organization and office structure, enhancing self-management, addressing health literacy, introduction of evidence-based guidelines, measurement and quality improvements. So from 2 to 3, you have advanced access options for patients, electronic health record, more complex care coordination, robust population management, address reporting, and additional technology. So, I mean, the second you get the HR, it checks a lot of these boxes, right? So, if does the HR have an App Store app or an Android Store app? Yes. So that checks out the advanced EHR and maybe some part of the access option for the patient. Maybe they can log into the office to see if they can be seen urgently or send a message or something like that. How about reporting and quality improvements? With the click of a button, you can probably compile a list that shows the average HbA1c change in your patients with diabetes type 2 over a year. So that checks that box. So, I mean, EHR is sort of becoming the main key for a lot of these, is all I'm trying to say, I guess. So, if you look at the scoring methodology, level 1, you need to be about 25 to 50 points, level 2, 50, 75, and level 3, 75 and up. So you need to pass at least 5. For 2 and 3, you need to pass all of them, and with a performance of at least 50%. So this data is somewhat old, but still, most are level 3 even several years ago. So if we said level 1 is disappearing, I mean, level 2 was 5% to begin with, so it's almost disappeared. So almost everything I see going forward will be probably at level 5. So if you look at more of the physician practices in Northeast and Mid-South, they are more accredited. I mean, because ultimately it's more tied to the reward, right? People unfortunately do need the carrots to do something, because I mean, inaction begets inaction, right? So if you're not doing anything, it's easy to not do anything. Just be comfortable where you are. So about 66% are adult primary care practices, 15% are pediatric practices, 47% of the practice are multi-site, and about 58 are small. They're less than 5 physicians. So if you're sitting there right now watching this, thinking, oh, well, I'm at 2 people's shop or 3 people's shop, how am I going to do this? Well, most are small. So yes, basically, to sum up, there's nothing to be afraid if you're a small practice. Going forward, it's more going to be level 3, and there needs to be a carrot approach to get people moving. So how about the accreditation policy? So you'll probably need the guide on policies and procedures, because you need to come up with your own. For a good policy, you need 5 components. Why? I mean, what's the context of this policy? Why am I writing this? You need what? What's expected to happen? Patient walks in the door, patient is checked in, etc. How? What are you using for this process? Like, what's the procedures you're using? Who are the stakeholders? Who are their roles, and when? What are the expectations? So a policy is not good if there's no expectations of data sets. So we're going to do a deep down on these cores. Let's start with core one, access during office hours. Basically, it boils down to enhancing access and continuity. Access during office hours means you have to provide same day appointments, telemedicine, after hours care, telemedicine. Again, telemedicine is a key driving force here. And then not just access for the patients, but if a patient is hospitalized or something urgent is going on, you need to provide some sort of availability to medical records, right? Unfortunately, most patients are not necessarily that in charge of their care. So if they're hospitalized urgently, they may know, for example, they're in a blood thinner, but are they taking a factor 10A inhibitor, or are they taking a direct thrombin inhibitor, or are they taking Coumadin? So like if they were, for example, in need of emergent anticoagulation reversals, so, or similar things. And then we need to provide electronic access, and then we need to provide continuity in care. So for this court, the practice is ultimately responsible, and they will provide instructions. And then the team will provide evidence-based care and self-management support. It needs to be culturally and linguistically appropriate. And we need to be assessing diversity, language needs. And then if needed, we need to be providing interpreter support. And again, from a looking at this core perspective, it's more about what can the office do for the patients. And ultimately, it is also more about not just putting things on paper and making them policy, but actually providing them as such. Like it's one thing for example, I was trying to do an in-store pickup yesterday, right? So it's all fine and dandy. You go online and they're like, oh yeah, we'll have your order ready. Oh yeah, we'll bring it out to the car. It doesn't happen. That's fine from a store perspective, from a retail sales, but from a healthcare perspective, it cannot. So whatever your policy says, you need to back it up. You need to ensure it's available. And this is where, from a regulatory perspective, you're going to run into most issues. So patient also needs to be part of this. So this is one example of a contract sort of you can make with the patients. So they need to realize that they're also responsible for their own health. Like they can maybe choose an activity, or they may choose to stay more physically active, and then they can sign this contract. And there's good evidence behind this that this actually leads to better outcomes. You may also need to hire someone to add to your team for this. So the team, you need to use a team to provide services by defining clinical and clinical roles. One big ticket cost item for PCMH accreditation is someone that's a PCMH manager or health coach. So this is one example job description that you may need to hire someone for. So may need to have bachelor's degree, and then their ability, like PCMH, work with PCMH, and then they will be responsible for a lot of things like engaging patients, risk assessments, documenting individualized care plan. One more important aspect of the core one, the enhanced access and continuity that you may not have had to deal with before, is the team huddle. So it's just what you expect from a team huddle, but there is typically a set different checklist way of doing it. Everyone does it in a different way. So typically everyone will create their own different way. This is just one example, but it needs to be set in a way that's just repetitive and conductive to ensuring it's more of a checkbox sort of approach. Who needs to be on the daily huddle? Everyone. What's the goal of the daily huddle? I mean, why are we doing this, right? Where? Maybe in the staff break room, maybe in the meeting room, but there needs to be set space. There needs to be designed time, designated time. So we're not pulling stuff randomly from like, oh yeah, just make Mr. Smith wait 15 minutes. We're just gonna do a quick team huddle and come back. What is this, McDonald's? Practice leaders should lead huddles. So like whomever is leading the PCMH efforts should lead this. And they're important. They will help you improve care, identify issues. So an example huddle agenda would be reviewing what's happening, planning, I mean, again, recognitions go a long way. It's not just getting mad at people, but also, oh, like Nurse Jackie did really good dealing with Mr. Warrior the other day or something like that. Daily announcements, what is going on, what is the message, and then what's the feedback you're getting. So you can, this is just one example. You can use something like this. But ultimately, huddle is important, and then core one is really important. This is scoring for core one. I mean, ultimately, they break it down to see if it's team-based, there's continuity, cultural and linguistic appropriate, and then some of these are must-pass elements. How about core two? So identify and manage patient population. This is an easier core because patient population is just data. I mean, I'm not going to remember 2,000 people. Some of you may, and good for you. I can't. So when I look at the data, I'll see what it is. Meaning an EHR with demographics. Clinical data, meaning an EHR with record constellation and good anamnesis. Comprehensive health assessment, meaning per USPSTF, were the preventive visits done? Again, data. And use of data for population management. So basically, core two is just data. Am I using the clinical data for evidence and evidence-based medicine to generate a list of patients, proactively remind them, preventive services, chronic care, optimal management, medications, etc. So am I using the data, for example, to remind those over 65 to get their shingles vaccines and stuff like that? So basically, you identify the population, stratify, segment, and then depending on how integrated your data is, I mean, you may have some high integration and then you can have some tailored interventions, or you may have some lower integration. So you may be just reminding people based on age or something. But ultimately, at the end of the day, all we're trying to do is we're trying to ensure we're providing the best preventive services we can. How about core three? So this is plan and manage care. Basically, we need to be implementing evidence-based medicine, identifying high-risk patients, practice specific criteria that this is based on, because my high-risk patients are not going to be your high-risk patients. So depending on where you are geographically, depending on what your patient population, socioeconomic status, and all those variables look like, you are going to have a different risk identification for patients. And we need to be using systematic processes to identify high risk or complex patients here. And ultimately, we need to do care management for self-identified high-risk patients, and then medication management and use of electronic records or prescriptions as well. So core four. This is again a relatively shorter one. So the most important one is core one. There's a lot of things that it brings and changes just the way you do things. The rest are more dependent on core one and more dependent on just the electronic health records aspect of it. So they're easier to implement. So providing healthcare support and community resources. So basically, you need to be a one-stop shop. So if patient needs yoga, and then if they randomly call your office secretary should be able to give them a phone number. So basically, to the extent a physician is only concerned if they give a prescription of metformin to a patient, and PCMH, a physician working in a PCMH is concerned if that patient is actually taking it, and the PCMH itself is ensuring that the patient is accessing the medication. If they don't drive, they are working with a pharmacy that actually delivers the medication. If they have issues with maybe temporary homelessness or anything you can think of, like PCMH is a one-stop shop, so it needs to bring together community centers, schools, faith-based organizations, social services, homeless shelters, whatever you name it. Like, it needs to be that one-stop shop for patients. For five, again, goes back to number one, right? So test tracking and follow-up, referral tracking and follow-up, and these are really easy to do on an EHR. And then you need to be able to coordinate facilities and manage care transitions like PCMH tracks hospital admission or ER visits proactively. You share the clinical info, obtain the discharge summary, and then it's not just among those, but it's just also among age So like if an 18, 19, 20-year-old wants to move into adult care, which they should, then you need to coordinate that. Or an adult moves into the geriatric care, you should. So like these are important care transitions in humans as well, in our lives as well. And then the last one. So measure and improve performance. I think this is one of the hardest ones because what are we measuring and how are we improving and how are we defining measurement and improvement, right? There's no set guidance. So whenever there's no set guidance, it's hard. So nowadays, the speed limit is 55, 65, 75, whatever. Back in the good old days, it used to be reasonable and prudent. Okay, what is reasonable? What is prudent? According to whom? So to an extent, we had the same issue here. So basically, you need to figure out what exactly is really measurable, what exactly is worthwhile to measure, what is affecting your utilization and cost, and what are the disparities in care to an extent, like are you identifying any? So this is one example I found from the Greater Richmond area PCMH collaborative quality dashboard, because these need to be public. They're looking at blood pressure control rate. They are looking at cervical cancer screening rate. They're looking at diabetes. They're looking at tobacco users as well as the quit rate. So it just depends. Another one is measuring patient experience. So this is one example of looking at it. Were patients happy, or are we using the clinician group consumer assessment of healthcare providers, the CAHPS scores, or how are we just compiling all of this? Again, we don't need to obey a set method here, but you sort of need to measure the patient experience. Ultimately, you also need to implement a continuous quality-driven improvements. So you need to do something, study it, act on it, and plan. It's just continuously going on. So it's like we always do this without realizing, right? I'm driving down the road. Oh, the speed limit is 55. I need to hit the brakes. Oh, I slowed down to 58. I need to accelerate. So these are all things we automatically do. But if we put this in a way that is on this graphic right now, it just sounds like something that's impossible to do. It's not. You just need to see what you're doing, gather the data on it. You need to see what you can improve, and then you need to improve it. That's all there is to it. So another aspect of this is that the performance has to be reported to all stakeholders. So individual clinicians across the practice, outside the practice, that there may be some data that needs to be reported externally to federal, state government, especially with immunizations and the COVID pandemic. You may also need to report syndromic surveillance to public health agencies and reportable diseases, depending on which state you're in. And then you should be using a certified EHR here. My favorite parts, limitations. I mean, it sounds too good to be true, right? What is going on here? Basically, you can be a patient-centered medical home, not a medical home accredited, but patient-centered practice without doing really good on the CQA. Boils down to four things. Do you have a regular doctor of place of care? Can you easily contact your provider by phone? Can you easily get care and medical advice on weekends or evenings? Are your physician visits well organized and running on time? So yes, you can provide all of these as a good practice, but still flunk the NCQA if you do not have any sort of written guidelines on this, if you don't do any sort of quality improvements. There's a lot of things to NCQA. Doesn't mean you're not a good practice, doesn't mean you're not patient-centered. So you also have to worry about the Kaiser Permanente or the big fish effect. So basically, what is the benchmark we are aiming for, right? So the big fish are going to find easier benchmarks. They're going to keep raising them, raising them, raising them. So it's going to be a hard time for you as a small fish in a big pond. And then CMS is a continuously ongoing improvement. So like that's a plan of improvement equal improvement if no one checks up on it. So if you decide to improve, do these quality improvement activities, but no one checks on it, or the federal guidance changes or the guidelines change. So it's a continuous battle on what you're doing and making sure it's actually effective and you're not wasting your time. Some people may come at me and say, oh, it's socialized medicine. It'll kill access to patients. After all, if everyone can't come in ASAP, there will be no access for anyone. No, it's not necessarily that. The more people have access, the better it seems to be. So basically, in 2014, for example, in average, about 18% of adults in the US did not have a usual place of care. In Vermont, it was only 2.8%. In Nevada, it was almost 30%. So a lot of states had a higher percentage without usual place of care. So basically, the more usual place of care patient has, the less ER visits you're seeing in that patient populace. So patients need to know where they should be going to get care, basically. Again, we can also say that basically US is not doing good in any of the measures. UK, yes, UK has socialized medicine, right? They have a single payer, they have a centralized federal, well, not federally, but government paid healthcare. And see, they are number one in a lot of things. They're still not doing a lot of healthy lives, and that's a whole nother discussion you can have. Doesn't matter. They are still number one in a lot of different things. And if you look, most European countries are doing way better in a lot of things than the US. So ultimately, we need to look at the nitty gritty. I mean, why are we doing this? Need the carrot approach, right? As we discussed. So what is the carrot approach? So there is a lot of money to invest and money to be made, and this is all evidence-backed. So there is some ongoing costs. There is going to be some transition costs. You may need to hire some people. You may need to change some things. You may need to hire someone to write some policies, but ultimately it's worthwhile. So this is just NCQA pricing. That's the cheapest of things you need to worry about. It's about 800 per site. Maybe if you're 1 or 2 person clinician, and the annual fee is only 155. These will change. You would need to get the latest info from NCQA. But a lot of the states, they do show that there's going to be increased income. And there may be both private and public payers that are paying more for your initiatives. And if you're accredited, and if from a CMS perspective, you may choose to get a 5% lump sum as an option under the alternative advance payment method, or you may choose to get or aim for the 9% MIPS up adjustments. So there's a lot of carrot involved as well. For example, a Geisinger Health System showed their return on investment was greater than 2 to 1. Or Colorado Medicaid showed that the median annual costs were $785 versus $1,000. Again, there's a lot of evidence and peer-reviewed publications that shows costs and savings associated with it. If you're interested, you can do a deep down after downloading our sites. There's also average costs per practices based on the component, but this is also extremely dependent on your individual circumstance as well, because if you're already paying for an HR, that's the bulk of your costs, that's done. If you already have a key staff member, like a clinical manager that can take on the role of the PCMH manager or lead the PCMH efforts, that's the second highest cost, and you can easily get this done. So ultimately, all in all, if you remember that patient we had, the 59-year-old Pacific Islander woman that had diabetes and was worried about COVID, and we were gonna prescribe her metformin, tell her to change her lifestyle, and send her home. So what should we do now? What are we going to do now that we are PCMH? What do we owe her differently? So we owe her a lot of different things, right? So basically, we need to ensure that she's getting the healthcare she needs. So she's getting the COVID vaccine. So she's getting maybe phone numbers for mole walking groups so that she can start getting active. She's getting the she's signed up for food stamps, so she's not reliant on McDonald's. There's a lot of different things you can do. Sky's the limit, but it's not just a 99203 office visit we owe her. We owe her just the social aspects and social determinants of health as well. It should be within our scope of practice to help her achieve the best life she can, because she may not know how, she may not know that these are important, she may not know that she can have access to different things. So ultimately, is it worth it? I mean, yeah, the evidence says yes. It's gonna be bureaucratic, but we took the Hippocratic Oath, and then we need to do no harm first. So we are just doing the 99202, 203 without doing any sort of real prevention. Aren't we doing harm? Because it's like, oh yeah, you're gonna get in a car accident, but it's okay, you don't need to buckle up. So it's like, we know what's gonna happen. I mean, we know what's gonna happen to that patient. We're just not taking any action because, do we really need to do that? It'll be cost effective in the long run. I mean, there may be upfront costs, but it'll be cost effective. And then there will be healthier patients, reduced healthcare spending, longer life, happy staff with less turnover. Ultimately, you'll get higher reimbursement. If you're PCMH accredited, there's an easier maintenance of certification. It will depend on what board you're with, but there's different carve-outs for all of them. And ultimately, CCM Health is ready to be your pathfinder for the artist and long way to get to PCMH. We are here for your regulatory concerns with regards to PCMH or what it may look like for your practice or office, and we would be more than happy to engage with you to figure it out for your particular practice and to come up with models and plans and all of that good stuff for your practice. Thank you.